Hello, welcome. Today we're going to go on a physical journey into biological science, and we're going to journey this way. So, very warm welcome to all of you. Just to introduce myself, I'm a postdoctoral researcher in biophysics at the University of Exeter, and my current research is in vivo diagnosis. So in vivo means in living organisms. I did my PhD at Durham, and that was actually in detergents. So washing detergents, the likes of your laundry detergent. But how this was related to what I'm doing now is that I use spectroscopy as a technique to analyze matter with light. So in this talk, I'll be covering a brief overview of peering into the depths of the body. So some of the history and some of the techniques which have been used and are being used, and some of the future techniques planned as well. And finally, I'll be covering actually the work that we do in physics in Exeter on optical biopsies. Just to warn you, some of the videos and images in here contain surgery. I will try and warn you, but if you are of a slightly worried about these images, then I will try and warn you. So just a little further blurb about me. My pronouns are he, him, and I'm bi, and I'm also one of the PRISM Exeter coordinators. I promise I didn't have to do anything to get a slot here. I've been a researcher in biomedical spectroscopy since 2015. So, how did it all start? So, diagnosis of disease was typically done by death, i.e., the patient died and you wanted to find out what caused them to die. So, autopsies have been being performed since around 300 BC. However, the term wasn't actually coined until around the 17th century. We also know that even before then, ancient Egyptians removed organs using slits during mummification. For example, the brain was drawn out through the nose, and they had these special canopic jars to place specific organs in. For example, the stomach, lungs, and liver here. One of the first examples of using an autopsy to actually establish the cause of death was in Julius Caesar's murder, where he was killed by his rival senators, and it was determined that the second stab was fatal, although the 22 other times that he was stabbed probably contributed to his death somewhat. We also know from 2nd century AD in India, from some Nepalese texts showing a decent understanding of human anatomy, and they were able to identify causes of death such as drowning, hanging, and strangulation, etc. In around 1200 AD, Europe started to become more developed and skilled in autopsies and started to use preservation so that they could preserve the specimens and study them later and compare them. And then around 1600 AD is when the modern autopsy and the field of pathology was developed. However, all of these are a little bit too late for the patient. So what about internal workings of the body of a living person? So the internal body was poorly understood before the 1800s. This included everything from eating and breathing and circulatory system, which we all hopefully understand a reasonable amount now. So in 1822, there was a gruesome accident of Alexis St. Martin. He was a Canadian voyager, essentially a fur seller, and he was shot with a musket accidentally. He survived the incident, and the hole in his stomach healed to the outside, what's termed a fistula, and he was cared for by a William Beaumont. So what happened with this fistula is that when Alexis ate some food, it emerged from the hole, and food was observed to remain inside for up to 17 days. And this provided an insight into digestion. So what Mr. William Beaumont did was tie some food to a string, dangle it through the hole, and then pull it out at various stages to see the state of digestion. And Beaumont was enslaved Alexis until 1833. And Beaumont was also credited as being the father of gastric physiology. However, it wasn't all bad for Alexis. He did live to age 79. And so that was the first investigation into the life of inside a living body. So this moves us on to the beginnings of endoscopy. So endoscopy is a camera inside your body. And initially, these instruments here were used to peer inside the body. One of the first inventors of what's called the Lichtleiter, or light conductor, as he termed it, was Philip Bozzini. And his device was for the examinations of the canals and cavities of the human body. And so initially these were just lit with daylight, so being able to see inside was quite difficult. With the invention of electric light, they started adding a small filament bulb to the tip. However, this proved problematic as obviously we all know filament bulbs get hot, and hence they were either burnt the patient or in some cases could start igniting digestive gases, which is obviously not good. We started then to develop flexible endoscopes in around 1911, and we started to have flexible endoscopies from then onwards. So these initial devices only tended to work on people who were very tolerant of the procedures, potentially including this Donald Trump-esque figure here. They developed other tools for looking in other natural and possibly unnatural holes. And here we're able to examine someone's bladder for bladder conditions, for example. And so nowadays we have what's termed an endoscope, which is flexible. And here we can see that we're able to articulate the end of the probe, so end of the endoscope. And there are some hand controls on the handpiece up here, which if you twist one of these dials, then the probe bends in a particular direction. And poor old mannequin here is about to be endoscopied. We also use endoscopes for other non-medical purposes. You may have heard of some of these, for example, in plumbing, where you might want to find out the reason why a particular sewer is blocked. On the International Space Station, they used it to look for condensation behind equipment panels. It's been used in nuclear reactors. For example, here is Fukushima, where they were measuring reactant coolant levels after the incident. And it's worth noting that the speckles on here are actually from the radiation affecting the camera. We can also use endoscopes in another way. If we make an artificial hole in the body, we term it laparoscopy, or keyhole surgery. And the advantages of this is that it minimizes the scarring and minimizes the recovery time. So, sorry, a warning, there's a bit of surgery, a bit late. So what we do here is we've got these ports which are cut through the skin, and then we can pass instruments in and out, and also collect specimens from inside with just minimal incisions. Here is about 4 or 5 holes in the patient's stomach, as opposed to having to have them cut completely open. And we can do procedures such as removal of the appendix, otherwise known as an appendectomy, gallbladder in a cholecystectomy, a kidney in a nephrectomy, an ovary removal in an oophorectomy, and we can remove things like tumors as well. And as we can see here, the patient is left with very minimal scarring, which heals quickly and reduces the chance of infection. We can also do in non-abdominal regions, for example, here, an operation on a knee with what's called an urethroskope. They do like their big words, I'm afraid. I feel sorry for Sophie. One of the other things we can do is combine those techniques with using a fluorescent dye to, for example, remove a tumor. So what we do here is we inject the patient with a dye. This is then taken up by the cancer, as cancers are typically very greedy for blood and oxygen. So the dye will diffuse most readily to there. We then illuminate the patient's insides with a UV light, and then we can therefore see where the tumor glows and the tumor lights up, and we remove those bits. it's worth noting the patients involved in this trial were very keen to sign up, as they were told they were going to glow inside. We then can remove that tumor and hopefully also able to see if there are any bits that are glowing left. That means we haven't quite removed it all. Another quite much more recent invention is actually a wireless pill cam, where it's a small, very small tablet or capsule. I say small, that's not that small. Capsule to swallow, which then through a battery pack that's worn, a receiver that's worn on the belt, we're able to then get these fascinating images of the pill cam descending through, in this case, the colon. And we can see that we're slowly taking pictures as we pass through. And more modern ones of these are actually able to swim around as well. This, I believe, is just a passive one, but some of them actually have a tail that can wiggle their way through your body. Using other optical techniques, we can also start looking through less deep through the body. You may have all heard of infrared thermal imaging. In fact, even in the pandemic, it's being used quite a bit to detect people with elevated body temperature. But if we change the wavelength slightly, we can start looking for veins and arteries, as we can either tell from the temperature difference, as the blood will be a slightly different temperature to the rest of the body, or in this case, we can actually look at the wavelength specific to the hemoglobin. And just a bit of a warning, here's some needles. But as a useful technique, if we combine that with a projector to actually shine an image onto the skin, we can then illuminate where the veins are. So if we want to try and either extract blood or deliver a drug, we are able to target precisely the cardiovascular system. And so this minimizes damage to the patient's surrounding tissues. And for some people with very poor circulation, for example, it might be very hard to identify where the veins are. We can also use light as a cure. For example, in a study that was presented on the BBC a little while ago, a group have developed a treatment for prostate cancer, where the patient is injected with a drug, and this drug is toxic when it gets exposed to light. So you place the patient in a very dark room to avoid unwanted exposure. You then deliver a fiber optic through a needle through the skin specifically to that area that is cancerous. The light then activates the drug and the exposed tissue dies. Some other more recent techniques include optical coherence tomography, which is a big word, but if you've heard of a CT scan, this is using light to essentially see through the layers of tissue. And it uses a technique called coherent light scattering, which I'm not going to go into detail here, but essentially it detects the changes in refractive index or phase to look at the optical density differences in the tissue layers. And its most common use is in examining the retina or the skin, and it's used quite a lot in detecting glaucoma, which is a disease of the eye. And in fact, I think one of the street opticians is now using OCT scans in all of its branches. And we can also use it on the skin. And the squiggles you can see here are actually the sweat glands in someone's skin. Using non-optical techniques, we can also peer through the skin. And I'm sure all of you are aware that we can do a fetal ultrasound. However, with more recent technologies, if we get enough data, we can actually start to compute a three-dimensional image of the fetus inside. Although the processing power for that is quite extortionate. We can also use a different wavelength of electromagnetic radiation closer towards the radio and microwave spectrum to do what's called terahertz imaging. And here we can identify the fact that this particular person is concealing a gun. So this is seeing through people's clothes. And so some of the airport scanners use terahertz imaging, although this output is usually suppressed by a computer algorithm. So essentially it would just highlight a blob here rather than actually revealing all of the, essentially making them nude. So finally, moving on to our work that we actually do at the University of Exeter in collaboration with the University of Bristol and Gloucestershire Hospitals NHS Foundation Trust, based in Gloucester. The technique we use is called Raman spectroscopy. And while I'm not going to go into too much detail, what we're able to do is we shine an instant light onto a sample of tissue, or it can even be non-biological in nature. We excite that tissue with the laser. And what we're able to do is filter and see the light that gives off, the light that is given off by each of the components in the tissue. So, for example, if we just had a sample of DNA, we would see a line on the screen which looks a bit like this. However, we know that tissue is combined of many proteins and DNA and RNA, as well as various glycogens. And so we end up with a mixture of all these, but we're able to analyze these results to determine what components are there and in what concentration. So what we use these techniques for is two of the main projects that I'm involved with at the moment. One of them is esophageal cancer diagnosis. So condition which is quite common called Barrett's esophagus, which is essentially an inflamed esophagus. And if anyone here has got repeated indigestion or acid reflux, continual problems of this can be a sign of Barrett's esophagus, which can then lead to cancer. Although 95% of the population with Barrett's don't know that they have it. So from post-mortem, around 370 cases per 100,000 are actually detected in Barrett's esophagus. So people live with it, and it does them no harm in a lot of cases, but it can just be an increased risk of cancer. The normal diagnostic method is to take an invasive endoscopic biopsy to remove a sample of tissue, which unfortunately leaves the patient looking a little bit worse for wear, and that's the inside of their esophagus after the procedure. However, if we're able to detect cancer earlier, we can treat it at this hyperplasia stage where we have a slight ingrowth. And that's certainly a lot easier to treat, or a lot more likely to survive, compared with when you get to this stage of invasive cancer where patient cannot swallow, and that's one of the first symptoms. And by this stage, the prognosis is not great. So what we propose is to use a small fiber optic probe which fits down the existing biopsy channel of an endoscope to take an optical snapshot of that particular point on the esophagus, to then read out the data, and then we pass it through a computer algorithm which can then identify particular components which may reveal its high risk or low risk of cancer. And the second project I'm involved in is what we term the Raman needle probe. And we're using this at the moment to try and detect lymphoma, which is a cancer of the blood. It's about the fourth or fifth most common cancer in the UK. So just a quick warning again of some slightly graphic images. Oops, next one. So this is our device here, or a prototype of us. So here, this is the conventional diagnostic method where somebody is having an invasive surgical biopsy to remove their lymph node from their neck. And what we propose to do is an ultrasound guided needle just passes into this lymph node and then is instantly able to diagnose them. So the analysis of these results can take several days, if not a week or so, to get the results back, whereas this would be instantaneous. And hence we hope to greatly improve the patient pathway for people who are suspected of having lymphoma. The current statistics show that around 50% of people who have to go under this operation to diagnose lymphoma do not have lymphoma. It's the swelling is just a result of an infection. And so if we can reduce the need for half of all of those operations, then that would certainly give a better patient outcome, and B, reduced costs to the NHS and other healthcare providers. So the concept itself is to take an intelligent optical biopsy at the tip of a needle in real time. And here we use the ultrasound to guide the needle to the lymph node, shine a laser down one of the fiber optics inside that needle probe, pass the light into our spectrometer, which splits the light into those components you saw earlier, and then to be able to identify whether or not that particular lymph node is high risk or low risk. And this particular probe, we have very inexpensive disposable tips, and then we have all the expensive parts in the handpiece. And here's an example of one of our prototypes on a sample of tissue, human tissue. So finally, just moving on to our future plans, we're planning on running some in vivo in human trials for esophageal cancer and lymphoma diagnosis. And then if that's successful, we may also look at other potential cancers and finally roll that out into a larger scale trial. Otherwise, I'd just like to thank you for listening. I'd like to thank all my partners at the University of Exeter, University of Bristol and Gloucestershire Hospitals, including Professor Nick Stone and Dr. Catherine Kendrell and Dr. John Day and the rest of the team. Thank you very much.